Good afternoon, everyone. On behalf of the USDA, HNRCA, and the seminar committee, it is my greatest pleasure to welcome Dr. Stefan Gravenstein. Dr. Gravenstein is the David S. Greer Professor of Geriatrics and Professor in the Departments of Medicine and Health Services Policy and Practice at Brown Schools of Medicine and Public Health. He serves as the Director, Division of Geriatrics and Palliative Medicine at the Alpert Medical School of Brown University and Associate Director of the Center on Innovation in Long-Term Services and Supports at the Providence VA Medical Center. Dr. Gravenstein has a long-standing interest in immunity, inflammation, cardiovascular outcomes, and aging, especially in the context of vaccines and the long-term care setting, and the topic of the majority of his publications. He also has a specific interest in quality improvement in healthcare, the culture of care, antimicrobial stewardship, and how to improve care transitions. Beginning in 2020, he became active in several projects related to COVID in long-term care. The title of his talk today is COVID and Older Adults, and he will show us data from his other work as well, and we look forward to welcoming him and hearing from him. Thank you, Dr. Gravenstein. To our audience, please post your questions in the Q&A session. Thank you.
Thank you. You should be able to see my screen now. So I'm going to talk about COVID in older adults. And at the back end, I'm going to do a little bit specific to some research and ways to think about answering tough questions. And I'll be talking a little bit about vitamin D to give you an idea about tough questions and maybe a way in which one could address these. So disclosures, I do receive grant support and do consulting with pharma that produces vaccines, most of the companies that produce vaccines, and one of them that produces antivirals. And I also have grants from the CDC and NIH. So we'll do a brief primer on SARS. I'm going to try to keep it brief, and I hope what I'm going to tell you about is the things you don't know about it instead of the many things by now that you do. And then we'll do a segue into immune senescence and then some vitamin D. And then we'll talk very briefly about how SARS differs a little bit from other viruses and how that can impact clinical outcomes, especially in older adults. And then understand how to leverage big data through health services research to study SARS-CoV-2 infection and other things. So this is my single slide to give you the background on SARS. So you may not know that SARS is an RNA virus, much like influenza. And it has a protein on its surface called a spike protein, which is the main ingredient in most of the vaccines, certainly the mRNA vaccines. And that spike protein on the virus has an ACE2 receptor that allows it to bind to the ACE2 molecule on the surface of cells. And when it succeeds in binding, it changes the conformation on the cell surface so that the cell then endocytoses the virus and releases it inside the cytoplasm to make copies. So step one in getting infected is having a virus land on a cell that has an ACE2 receptor. The graphic here, the person, shows density of ACE2 molecules on cells in different organs. And you can see in the red organs, the kidneys, small intestine, and testes, they have the highest concentration of ACE2 molecules. The slightly less red, the orange, large intestines, the heart, have lower density, and then the lungs and vasculature have the lowest density, including the oropharynx, not many receptors in those spaces. So when the virus gets in, actually the easiest place for it to bind is in the intestines, as opposed to in the lungs. To get into the lungs, it has to be in remarkably small particles to actually make it all the way in. And if it's in a larger droplet, it gets deposited and doesn't make it into the small airways, which is where those receptors are. So meanwhile, those larger particles can drop in the mouth and other places, and it can get swallowed. And if it makes it through the acid bath of the stomach, it can infect the intestines. It's a reason why wearing masks are relatively effective, because it stops those larger particles. that have the greatest chance of surviving until it lands on tissue that has an ACE2 receptor. Then once it lands, it makes copies of itself and then gets sent through the bloodstream to other tissues, and then it can infect everything else that has ACE2 receptors. So as you work your way clockwise around this figure, if it gets into the brain, it's why you can get brain fog in part, headaches, stroke, and delirium. And I'll say a little bit more about stroke in a moment. In the nasopharynx, it can get into the tissues that the olfactory nerves pass through. And it doesn't actually infect the olfactory nerves, but the tissue around it, and that changes the chemistry, so the smell doesn't work anymore. In the same way, it can affect taste, giving you dysgeusia and a sore throat. In the lungs, it can cause pulmonary embolism. It can cause a form of pneumonia. And when they recover, they can have lung scarring. Often when they get infected, and they, even in people who are asymptomatic, on CAT scans, you can see evidence of infection in most people that get this infection. So how severe the lung damage is correlates with inflammatory markers like C-reactive protein, IL-4, IL-6. And if you think about smokers specifically, they have a higher level of ACE2 expression. So they may in fact have a greater risk for having outcomes related to COVID and their underlying lung disease. Kidneys have this high expression of ACE2, and because of that, people who get critically ill often will have kidney trouble. And the urine potassium might actually be an indicator of ACE2 function. So you can get albuminuria, and if that's high, it would be evidence of systemic spread to the kidneys. So the vasculature, the lining of blood vessels, these endothelial cells, when they have ACE2 receptor, they have ACE2, and when the virus binds to them, they get an endotheliolitis. What that means is that those cells can rupture and release something called von Willebrand factor, which is a huge molecule that has lots of places where the SARS virus can bind, and it also binds platelet. And so this long stringy molecule, as it's released into the bloodstream, becomes like a snowball. It's a trebuchet thing that sort of flips around and gets larger and larger and can form emboli that can land in the brain, contribute to headaches, can land in the lungs, contribute to pulmonary emboli, and can cause skin lesions like those that you see in the bottom right, levator reticularis, the ones on the bottom right in the legs, and something we've called COVID toe, which looks like frostbite of the toes, or on the left side in the fingers, can be pretty painful and can itch and so forth. And that petechial rash is part of that levator reticularis. Working your way around to the left, intestines. So diarrhea is a common thing, and about before vaccines, about 74% of folks would present with some sort of GI symptoms. 70% would have some changes in taste or smell. About a quarter of them would have a fever and skin findings in 20%, and conjunctivitis in about 2%. So that's the receptors that are on the lining of the cornea. This is among those that are symptomatic. Absent vaccine, about 40% or so of folks are not symptomatic. And that's probably because of cousins of SARS-CoV-2 in the beta coronavirus family infection earlier in life, which might give you a little bit of immunity, enough to keep you from developing symptoms. It's interesting because women are less likely to be symptomatic than men. And at least one conjecture is that's because women have more often have the stereotypical role of taking care of their kids when they're very young, snotty nose, they come home with a common cold, beta coronaviruses, and may have actually this lifetime exposure that differs. In people who get infected, they start shedding virus. It's usually detectable in the stool 1 to 3 days before you can detect it in the nose or mouth. And after it clears, typically by 70–80% will be cleared by day 8 after initial exposure. But on average, you can still find an RNA signature in the stool on average out to day 17 after inoculation. There's some reports that people can stay positive as long as 7 months after that exposure, at least by PCR testing, which doesn't mean they're contagious. It just means that they still have expression of virus. So when we think about how deadly and contagious this is, you've heard about the 1918 Spanish flu pandemic. So this was a brand new strain of flu, an H1N1 virus that's now been in circulation since then. And at that time, since it hadn't been in the population, it was quite deadly and relatively contagious. Worldwide, some 20 million people died. The original SARS virus, a little bit more contagious than Spanish flu and not quite as deadly as that Spanish flu. And then the Delta variant was perhaps a little bit, caused a little bit more disease, but 30 to 50% more contagious than that original Wuhan strain. And then if you add to that the Omicron, a little bit more contagious, maybe not, a little less serious illness. And the BA2 variant, again, slightly more contagious of those Omicron variants. There's now a couple more of those, Deltacron and a few others. If you give a vaccine, it takes this and it reduces how contagious it is some, but it dramatically reduces the likelihood of dying from it. It's much less deadly with a vaccine. So I'm talking about old folks now, and in our country, nursing home residents had the largest contribution to COVID mortality. In the early wave of COVID, about 40% of the national mortality was in nursing home residents. And then gradually that's diminished. Now I think it's about 20% of all the mortality is in nursing home residents. And that continues to decline. And the only thing that changed early on out of those first few months was access to protective equipment. So by wearing masks, even if you get infected through a mask, the load of virus that you're infected with is dramatically less. And there's a relationship with how sick you're likely to get with how big your viral exposure is. So to give you an example, you might recall the Diamond Princess, which was anchored off the shore of California for a while. And in that group, their infection rate was about 60% with about 40% asymptomatic, sort of what it is for the general population. So another cruise that happened just slightly after that, going from Argentina to Antarctica, also had an attack, and the infection rate was pretty similar to what they had on the Diamond Princess, but about 85% were asymptomatic. And really the only difference was they didn't have masks on the Diamond Princess, but on the Argentinian cruise, the crew was wearing N95s, and the people on board were wearing regular surgical masks. And so it's assumed that the reason it was they had less illness was because when they got infected, they had a much lower viral load in that initial inoculum. So here's COVID-19 in nursing home residents. And the light blue line is confirmed cases, and the dark blue line is COVID deaths. And you can see this big peak at the front end is the thing that drove this national contribution to mortality. And way over here on the right, this is now the Delta wave, and you can see how it was kicking up again. And this is where vaccination started, on the backside of this. At this point, 78% of residents had been vaccinated, about 38% of staff by January 10th. And you can see how vaccine was driving down mortality down here, as well as people testing positive. So why is it that older adults do worse with infection? And so we'll talk a little bit about why this is the case. And at least some of it that I'm not going to talk about is multimorbidity. If they have underlying obesity, hypertension, diabetes, and heart failure, which 60% of them do, their risk for having bad outcomes is dramatically higher. It counts for about 60% of that risk. And that was published by one of your own a couple of years ago, last year maybe, 21, yeah. And there's an impact of nutrition on infection also, so the immune system can work the way it's supposed to. So as we get older, the amount, the way our immune system does what it does becomes gradually impaired. So we have interleukin-6, which does a couple of things. It produces a fever. And as we get older, when we get infected or get some other challenge that would kick up interleukin-6, it comes up more slowly, and it also goes down more slowly. So because this is one of the chief drivers of fever, the old people don't get quite as hot. They don't stay hot quite as long when they get their fever, and it participates in improving viral clearance, and they get less efficient viral clearance. This is especially important for things like influenza, which is temperature sensitive, maybe a little less so for SARS-CoV-2. The mucociliary function, this is the hair-like cells that line the trachea down as you get to the lungs. That escalator doesn't work as effectively. There's fewer cilia and they don't sweep as much, so there's less cough and less efficient viral and mucus clearance. Like with interleukin-6, which is a cytokine, the other cytokines also have a delayed increase, delayed normalization, lower peak, and that means that when they get sick, their inflammatory response is a little bit more slower, so they don't look quite as sick, even if they have plenty of virus around. And because it comes down more slowly, the time to recovery is a lot longer. So the myalgia and the malaise and the headaches that are produced by cytokines come up and go down and aren't as severe, even if they end up causing a heart attack or a stroke or some other severe outcome. The cytokines also push T cell help. If you had a normal repertoire of cytokines, the T cells actually can respond. And so your response to infection and vaccination is less, and it's less durable. So they need to have extra help in getting those T cells to kick in and support immunity like you get from vaccine or from natural infection. A lot of older individuals have reduced nutrition. That's something I probably don't have to tell you anything about. And this is in part results in reduced physiologic reserve, more difficult rehabilitation, and also can affect potentially immune response and response to infection. And then finally, with brain aging, the blood-brain barrier usually keeps things out of the brain that are swimming in the blood, like cytokines. And when that gets leaked for delirium to the fire. This can also affect sleep and appetite and change the quality of how we present clinically with cytokine storm. So with immune senescence, you get a change in T cells with age, with reduced number of naive T cells, reduced B cell stimulation. So the B cells make typically less antibody. They make less neutralizing antibody, and they have problems with isotype switching so that the specificity and the avidity of those antibodies are somewhat less. You get an increased pool of the memory T cells, and those are somewhat dysfunctional. They don't produce quite as much as interferon gamma and cytokines, and contributes to the lag in the kick-up of cytokines and the cell communications to really rev up that immune response. Dendritic cells present antigens to T cells, and their function is also declining with age. And the MDCs are affected by disease, and the plasmacytoid dendritic cells are specifically with age, and they're less able to process and present antigens to migrate cells to the infected site, like the lungs. And there's reduced toll-like receptor expression. So a nice summary slide is from Hirakawa. This is now ancient, from 75. And it is a classic experiment. This is done with BALB/c mice. And you can see that, so I'm going to walk you through this a little bit. All of these mice in this graph are neonatal mice. The control group is a neonatal mouse that has nothing done to it except getting a vaccine. And then all the other mice have their thymus taken out and then replaced with an increasingly older thymus. So they're all neonatal mice with older thymuses. So you give it a neonatal thymus back, and the antibody it produces is about the same. But if you give it a 3 or 6 month old thymus, it produces a little less antibody. These mice live on average to around 30 months or so. So at 33 months, most of them haven't survived. And the amount of antibody they produce when you put a 33-month-old thymus back in is a lot like not giving them a thymus at all. And so the thymus is sort of the university for T cells. And it tells you about the problem of, when you become 100, that your immune system just isn't what it was, and you'll have more trouble responding to infections and vaccines. Here's data that we've done in collaboration with folks at Harvard. Alex Balaz is one of the folks we've been working with, and they do the neutralizing titers on our study. So we've been following a group of nursing home residents and healthcare workers now since 2019. And so we have blood from them over time. And because we have healthcare workers, we also have a relatively healthier group than the nursing home residents. So when you're looking at this, I'm going to walk you from the top left. The white dots are people who have not been previously infected with SARS, and the red dots are the ones that have been previously affected. On the vertical axis is neutralizing titer, antibody titers, where higher is better. And that top left panel is neutralizing titers to what's in the vaccine in that original wild type Wuhan strain that came around March of 2020. The summer strain, which is D614G, you see next. And you can see in both of those on the horizontal axis, you have age from 20 to 100. So most of those people that are in the 60 to 100-year-old group are people who are our nursing home residents. And so you can see people who have been previously infected, they have good responses to the vaccine that are quite a bit better, and it's not affected by age. But if they haven't been previously affected, you can see a downward trend in those antibody responses. So that's just immune senescence plus multimorbidity. And you see this as you go across to the alpha variant strain, the beta variant on the bottom left, the gamma P1, which is the beta is the South African and gamma is the Brazilian strain, and then the delta on the far right. And you can see that as you start drifting from what that original wild type was, as you add these mutations on, the ability of the antibody to recognize and neutralize is less. But if you've had a prior infection, it does a pretty good job of still adding to that protection. Absent vaccine, by the way, those red dots would be a lot lower. This is what you get a couple of weeks following vaccination and the range across this age span. Now, in each of these, and I'm not going to show you the Omicron data, the difference between the wild type and the D614G is just a few amino acids on the spike protein. And as you get to the alpha, beta, gamma, and delta, it's a handful again on the spike protein, either on the receptor binding domain for ACE2 or the trunk or other parts, but typically only a few. By the time you get to the Omicron, on that one spike protein, it's not just a few, it's actually over 24 changes, of which half of them occur on the receptor area of it. And it's one of the reasons it remained quite contagious. Even though vaccine could have protected some, 2 doses just didn't do the job. One of the things that I'll be showing later on is what happens when you get that third dose, the boost. So what's the debate here? You have clear data showing declining antibody, 80 to 90% antibody reduction in over 6 months with the vaccine. And what I'm going to show you here is that the decline in antibody does not itself necessarily mean a rise in disease. And there's a strong correlation between neutralizing antibody and disease risk. So we have studies showing this decline and where antibody goes to the lower limit of detection, but yet there was still some evidence of protection. And so here's one version of this. This is in that group of 150 we were following, now out to 6 months out. And our denominator is declining over time because we have drop off. And what this is showing is proportion of people where the neutralizing titer is at the lower limit of detection. So that prior graph was done here 2 weeks post-vaccination. And you can see almost everybody ended up getting neutralizing titer. 12 out of 75 did not, 16% did not. But by 6 months, 70% no longer had detectable neutralizing titer in the group that had never been infected with SARS. In the group that had been previously infected, it dropped down quite a bit. 35% no longer had detectable, but even in the healthcare workers, it came down some. So that's 6 months. And that was the reason that drove a recommendation to have a boost to try to bring up those values. When we look at this data in a slightly different way, this is now, what about the risk of having disease rather than just declining antibody? So there was evidence of increasing breakthrough only among nursing home residents and not the rest of the group. So here are the data for this. So this is looking at 56,000 nursing home residents in this group. And what I want you to look at is this box right here specifically. And this is getting SARS and less than 90 days after that primary series, the underlying infection and breakthrough disease rate was about 0.4. And you can see when you got to 6 months, it had quintupled to 2% of this population now of 26,000 people that were here. So this showed that there was an increasing breakthrough and that it was time to do a boost. So that's where that recommendation came from. So rise in the breakthrough disease is more obvious in the nursing home residents than in healthcare workers. And it doesn't mean that there's a vaccine failure. It just means they don't have quite the same level of protection because it was still working to keep them from dying, even though they were increasingly likely to get infected. So breakthrough, for example, 15% of Dade County hospitalized for previously vaccinated may relate mostly to exposure risk than waning immunity. So these young individuals are being hospitalized much closer to vaccination, but there's a base fallacy rate that we have to worry about in terms of how you measure it and the county exposure level. So I'm going to say something more about one of the misconceptions about is it unsafe to live in a nursing home, and if nursing homes have poor quality care, does that somehow set them up to have more SARS infection rate and mortality? So what can you do to fix this? Well, you can increase the dose. Moderna dose is actually quite a bit higher than the Pfizer mRNA vaccine dose. And so that might be some part of that signal which suggests the Moderna vaccine might be a hair better than the Pfizer. But I think relative to what they do, they are essentially comparable. And I don't think I would care which one I got. Similar strategy has been done with influenza vaccines. So they have a high dose influenza vaccine. That's 4 times the standard dose, which helps with old people having better responses and keeps them from getting hospitalized. You could add an adjuvant. An adjuvant vaccine for flu is out there. And this is now against the standard flu vaccine. And we have published in cluster randomized trials that also this approach reduces hospitalization rates in nursing home residents. You could do other things like addressing deficiencies. And so I'm not going to do a segue into vitamin D. So cells of both the innate and adaptive immune systems express the vitamin D receptor. And so this includes the monocytes, macrophages, the dendritic cells, B and T lymphocytes. And these latter groups are things that are sensitive to what the thymus is doing. Micronutrient deficient, and we're talking about vitamin D receptors now, are linked to poor clinical outcomes during viral infections. So there's a theoretical benefit if you give them a nutritional supplement with vitamins and trace elements in people who are malnourished. It's less clear about whether that helps people who are not malnourished. So deficiency in vitamin D, zinc, and selenium have been implicated for worse outcomes with COVID. And there's been lots of publications around theoretical vitamin D benefits, such as the cathelicidins and the defensins induction to reduce viral application and inflammation. Vitamin D is supposed to raise the anti-inflammatory levels of these cytokines, sort of pushing toward a Th2 response, which withers with age, and lower the inflammatory cytokines, the Th1 response, which is, as you get older, you have this declining Th2 in favor of Th1, which is part of that inflammatory aging profile. So a Th1 response is associated with worse outcomes in COVID-19 patients. So to do this graphically, this is from Dewan, published just in the last month, a nice graphic. And so you can see the virus up here. It attaches to the ACE2 molecule, goes in, makes copies, expresses TL3 and TL7 receptors, flips on NF-kappa beta, and works its way to get copies. And then as it comes out, the cell also is starting to produce type 1 interferons and type 3 interferons, inflammatory cytokines. Now, in the presence of optimum concentration of vitamin D, this top panel, it pushes a Th2 response, and you get these anti-inflammatory cytokines that are produced. When you have a vitamin D deficiency, it favors a Th1 response, so you get more of the inflammatory things, so you may look sicker. This also gets a Th17, which gets a couple of other cytokines that then contribute to an overall cytokine storm. So the idea is that the inflammatory cytokine excess occurs prominently in severe COVID-19, and that maybe you could modulate it with vitamin D. So there are just two studies I wanted to highlight, and then I'm going to talk about some meta-analyses. In the European countries where they were looking at vitamin D average levels for those countries where it was less than 50, they had higher COVID death rates than those countries that it was greater than 50. And so they looked at the pre-vaccine era and the mean data from literature review and assigned roughly a twofold risk for being in the less than 50 group compared to the greater than 15 group in every 14-day period after initial infection. These mortality differences held up for countries with the lowest sun exposure but had the highest vitamin D. So an interesting observation. The second one is looking at socioeconomic deprivation, which I've abbreviated SED down here, and ethnic disparity. And this is a UK biobank study where they were looking again before vaccination was offered and controlled for age, sex, ethnicity, obesity, tobacco, systolic blood pressure. This is supposed to be deprivation, Townsend Deprivation Index, personal health rating, long-standing illness supplements, vitamin D, and skin color. And they noted that Asian and Black ethnicity was associated with COVID-19 severity, but the socioeconomic deprivations mediated the ethnic effect across all of these groups. And so this had the highest overall signal of mediation of any COVID-19 risk factor. It's an observational study, so there's some limitation when you assign causality in this. So here's the systematic reviews. And again, there's a randomized control trial I'm starting with just to give you an idea of the trials that are in these things. So this is first one is by Mirai, and this is an RCT where they gave a single bolus dose of 200,000 units, and they found no effect on hospital length of stay. This is a group of 240 people that were hospitalized in Brazil. This second one is 100,000 units bolus dose at hospital admission, also did not improve outcome, length of stay, ICU need, or mortality, but it did improve vitamin D level. The vitamin D was, before it was 17 versus 16, and the vitamin D level went up to 29, and didn't make that level of 50 that was used in that study that I mentioned a moment ago. A third randomized control trial was placebo-controlled, and here they gave 4,000 international units daily. And this was also before time of vaccination, and they gave it for a total of a month, sort of like a pre-exposure prophylaxis. They had fewer PCR positives. So it's a study of 321 people, 94 in the vitamin D group, 98 were in this evaluable group, and they had 6.4% versus 24.5% that got this. So of these study designs, this was actually the best design. And one of the things that was better about this is that they weren't using bolus dosing. I'm sure that plenty of you have a lot to say about that approach for doing this. These were frontline healthcare workers in Mexico City, 4 hospitals, and really it was a study on chemoprophylaxis. The COVIVID study is a meta-analysis of the randomized controlled trial. And here they had 6 such studies that accumulated 550 COVID-19 patients. Placebo-controlled vitamin D treatment was what they needed in this. And they used an outcome of severity, sero or RT-PCR positivity, and they looked at mortality, ICU care, and other adverse events. This is 2 multi-center, 4 single center, 1 double blind are in these trials. And their outcome was a 0.6 relative risk for having any of these endpoints in terms of their overall benefit, and I'll show you a little bit more about that. But they didn't see a benefit in mortality or seropositivity, and they didn't see a difference in by RT-PCR. They did see a difference in RT-PCR positivity in 3 studies, and severity in these all 6 studies. And severity included symptom severity, which things like ICU care and needing a ventilator. A second systematic review, which included some observational studies, a total of 11, and vitamin D supplements, and especially, so sorry, I'm going to go back here. So here they used both cholecalciferol and calcifediol, so they weren't using the same supplement across the studies. Yeah, but they noted a significant reduction in ICU admissions and mortality, but not in diminishing the duration of hospitalization once they were hospitalized, so outpatient. So this is sort of a summary from the first one, the Veracazado. And what you can see here is one of these articles has now been retracted, and it had one of the biggest event differences between the 2 groups. If you take, and then there's Castillo, and there were issues with that. So I'm going to talk about Castillo in just a second. So when you look at this, this is ICU, this is RT-PCR positivity, and these 2 drove the overall 0.6 value. And then there's Castillo here, which is a driver of all of these, even though it's a relatively small sample. So each of those to get that outcome. So when you look at bias in these, so this is published by Banya, and this is the Castillo study here. So it has a domain 1 bias, and that is arising from how they did the randomization. And it's a high concern. And if I were to talk about, you may have seen the 4th dose Israeli study in people over the age of 60. So in that study, they took, they had over 1 million people who were offered vaccine. And then they followed those who did and didn't get vaccine. And they concluded in these 60-plus-year-olds that after a month, it no longer gave the same protection against infection. They didn't follow it long enough to find about hospitalization. And so they thought that it was evidence that they needed to go quickly to a 4th dose to get that added protection. So the problem with that is when you do an observational study like this, the first people that step up for the vaccine are those people who think they have a great risk. And so they've been extra careful with their behaviors, or that actually do have a great risk and remain careful with their behaviors. So then they get their vaccine, and compared to other people who are more lax with their behaviors, who aren't getting a vaccine and getting infected, it may create this perception that, at least in the first month, that it has greater benefit than it actually does. As those people get vaccinated, the ones that have been extra careful but aren't really at greater risk may allow themselves to change their behaviors and then be exposed. And so the protection, the apparent protection from infection may actually decline, not because of declining antibody or protection by vaccine, but just because of behavior change. And so those observational studies from Israel suffer from that problem. So the summary here is there's high variability in vitamin D dosing, including bolus dosings to 4,000 units daily, and which vitamin D they used, calcitriol in 1. Sometimes they received other supplements. So in one study, they received magnesium and B12. In the Castillo study, they were also on hydrochloroquine and azithromycin as part of their standard care. One of them was done as chemoprophylaxis that had one of the biggest differences. There wasn't any reduction in length of stay for hospitalization. They did see reduced ICU admission and mortality, but only if you include the observational study. And starting earlier seemed to do better. So it begs the question of, is the time when you present with your COVID the right time to start, or should they be getting vitamin D ahead of time? If you exclude the Castillo study, then these outcomes become non-significant. So my conclusion about this, vitamin D supplementation early might improve outcomes, but there really aren't high quality enough data yet to draw a conclusion on this. And probably the design would be better if they did this more like the chemoprophylaxis study, where you give the vitamin D ahead of getting sick and then let them run. So that was the healthcare workers in Mexico. And if you're vitamin D deficient, might you also then be deficient in other essential nutrients that are active in the immune system? And should you do it as a multiple supplement, or do you want to just do vitamin D? Okay, so now some information on how SARS-CoV-2 infection differs from other viruses. So one main difference, and one of the new learnings, I think, for me as somebody who's been, I'm merely a geriatrician, but I've been studying these infectious disease things in old people now for a few decades, was that the large proportion of people who were asymptomatic initially, and now with vaccination, even greater proportion. So with influenza, sort of as a comparison, the period where you might be shedding an asymptomatic is measured in hours. With SARS, it is measured in a day or more. So if you're going to get symptomatic, you'll be shedding virus and potentially infecting other people for at least a day, and if not vaccinated, maybe even 2 or 3 days earlier. If you don't become symptomatic, you're shedding and never know that you've been potentially putting other people at risk. People who are asymptomatic means, by definition, you can't tell they're sick. They'll still be going to work, and they could be shedding virus. And if you're in that environment and you're doing caregiving for somebody at risk, you run the risk of being infected if you don't stay vigilant and continue to mask yourself. So having folks around, releasing them from having to mask and so forth, changes the work environment to one where it changes how I, as a practitioner, think about wearing a mask. So when I still travel, I get on planes, but I'll wear an N95 mask and a second mask over it to protect myself from traveling, because when I go back to take care of my patients, I don't want to infect them. So backing up again. SARS produces a viremia. Flu typically doesn't do that. It can even infect the brain, but SARS does this as just one of the things that it does. SARS infects the intestines, whereas flu is stuck in the respiratory tract primarily. SARS damages the endothelial cells, binds to platelets, von Willebrand factor, brain tissue, kidneys, and testes, something, again, that the flu virus doesn't do. You can get long COVID in 15 to 30% of individuals. And in our VA population, we looked at a group of about 8,000. We're presenting this at the American Geriatric Society meeting next week. We had about 16% of our veterans who were living in a VA nursing home who developed long COVID, and we defined it as a new symptom more than 2 months out relative to people who weren't infected. It sheds longer than flu. So in flu, when you or I get infected, typically we will only shed virus for 2 days, maybe up to a week. If you get infected despite vaccination, maybe a day or so. For SARS, it's 3 to 14 days that you're shedding. So in the sports league, when they were doing daily PCR testing, these athletes who, when they were infected, despite vaccination, were still 30% were still showing PCR positive at day 8. So this tells you that the sort of the time constraints that we typically think about, you really need to be careful a little longer out. Some people shed out to 3 weeks in the unvaccinated, and through stool, as I told you before, you start shedding virus usually within a couple of days of getting inoculated, and on average for 17 days after that date through feces. I don't think fecal oral is a common route of transmission, otherwise public bathrooms would be spreading this when you flush those open toilets. But it is interesting that you can shed for such a long time. So something the flu virus doesn't do, it doesn't turn on our endogenous reverse transcriptase. You might recall that when we first learned about retroviruses like HIV, one of the things they do is they bring with them a reverse transcriptase that can take the RNA code and turn it into DNA and then insert it into human chromosomes. Well, SARS in tissue culture seems to be able to turn on a native reverse transcriptase, we call it line 1. It does this in tissue cultures with lung and kidney cells, and can produce DNA and then get it inserted into the chromosomes of those lung and kidney cells in tissue culture. Those cells can then produce new DNA new RNA from that DNA that's now encoded. And that new RNA is really chimeric peptide that's part human and part virus. And that gives you a mechanism if you have this chimeric protein where if your body's trying to figure out which cells are infected and so forth, and now it sees cells that are expressing proteins that have human characteristics as well as virus characteristics, that it might be confused and might actually produce an autoimmune response, one of the hallmarks of long COVID. Like flu, SARS-CoV-2 can infect other species. So in flu, the natural reservoir for this virus are water fowl, so ducks and geese and so forth, and they do get runny beaks when they get infected. But for SARS, bats and louse, and now it turns out white-tailed deer can get infected, and they can transmit it to each other, and it can evolve among white-tailed deer to get new strains and then potentially reinfect people again. So that's all been published in the last year. So here's the last segment of this talk, how we use big data. And I'm going to show you a little bit about one of the outcomes of this. We developed a clinical academic partnership as a platform for research, and we wanted to do this so that we could rapidly respond to the clinical questions that were coming up in the field and directly look at the data. We were constantly wondering about the conventional wisdom and whether we were getting it right, and it allowed us to sort of move faster in how we did testing and absenteeism and rapid test versus PCR and so forth. This was sort of a balance between how we traditionally do research, very slow, and for publication, versus a need for speed, getting answers as fast as we could. Our first partner was one we had just developed as a partner in the year before the pandemic. And it's the largest nursing home chain in the country at that time, over 325 facilities, 300 physicians and nurse practitioners, and some 40,000 beds. And one of the features is that they had a single electronic health record where we could look at everything from laboratory data to what symptoms they were getting on a daily basis. So when the pandemic came around and they started getting vital signs 3 times a day and doing a symptom screen for a couple of dozen different symptoms, we actually had real-time access to that and could figure out what was going on. And we had a weekly meeting to sort of address the findings and then talk about who was getting sick and who was getting vaccine and not, and so forth. And we've published now, I think, over 30 papers from that collaboration. Here's the spread of those facilities across the country. So you can see we had some national representation. So this is just one article that came out from this collaboration. And there's a lot to see here. So you can see some of the symptoms we were looking at and how often they occurred. And this study was to look at people with PCR positive versus negative, and whether they were symptomatic or pre-symptomatic, tested at the time they didn't have symptoms because there was COVID in the building, or asymptomatic. And you can see the likelihood of developing antibody from an infection was 50-50 if they were PCR positive. And if they were PCR negative, they made a little less antibody. So a second publication out of this was looking at case mortality rates. And you can see so what this mostly says is that the case fatality rate is on the vertical axis, and this is the county prevalence on the horizontal axis. So if there was high county prevalence, you had high mortality, and if there was low county prevalence, you had low. And we also tried to link this to star rating and so forth, and it turns out there's no relationship with a 5-star rating system and quality of care. So this virus doesn't care about your rating systems. If you're doing your masking, even if your other aspects of quality are rated high or low, you're equally at risk for dying from this. A third one from this collaboration is this study on what are the predictors of 30-day mortality. And you can see some of these are like that paper from Tufts talking about what are the risk factors for severe outcomes that was published last year that I showed earlier on. They show up here again, chronic kidney disease and diabetes. But age, functional impairment, cognitive impairment, and symptom severity were all here related. So on this left panel, this was age. So the oldest people had the highest mortality, this red line here, down to the less than 65. So that's partly immune senescence in nursing home residents, but there's a contribution of multimorbidity. Here's the second one. This is physical functioning. So in the nursing home, all residents get assessed every 3 months for their activities of daily living. So this is a 0 to 4 point scale where 4 is completely dependent on somebody else. And there's 7 items they measure on this. And so the highest score you can get is 28. That's the most functionally impaired. So these are the people that have the most hands-on care, and their mortality was also the highest. And again, I think that's a viral load and exposure if the healthcare worker infected them. And then on the far right, this is a cognitive function score. So as you get higher scores, you become more demented. And so the people who are the most demented will also be the ones that are most impaired, but they'll have the most hands-on contact with caregivers, redirecting them and so forth. And they'll be less able to wear masks and do other things on their own. So their risk is higher the more cognitively they are impaired they are. So this is now 30-day mortality risk declined over time, even before vaccines. And so this is how high it was early on in this group. And we have this mapped on here, the symptomatic group on the red line, average of both groups, and the asymptomatic group down here. So the assumption here is either they got a lower load of virus exposure or they had pre-existing immunity. And the main thing that happened between March 15th and May 15th is that people started wearing masks. Wearing masks and having masks available to wear. They all, they might have been reusing things. They had workarounds, but it was a challenge here in those first months. So here we have cognitive function score, again, as colors of dots, where red is the highest cognitive function score and the most physical impairment. You can see the red dots are up here. And the yellow is the best cognitive function score and the least functional impairment. And it grades up for mortality. So this data comes from VA nursing homes. So here we have about 8,000 people in our sample. And what happened was in April of 2020, April 15th, the VA decreed that everybody should get a SARS-CoV-2 test. And so right around that time, give or take a day, we just organized them as if they all got it on that day. We had temperatures, again, recorded in the electronic health record on a daily basis. So the people who tested negative, this is how their temperature ran. And the people who tested positive on this date, this is how their temperature had been running in the 14 days before that test was done. So to look at this another way, this is the proportion of people who are testing with a temperature that's greater than 38 at this point, and it's only about 25% that ever get to a temperature of greater than 38. So that's 100.4. 50%, if we do it at 37.2, this is how the curve looks. You can see that 5 days before, most of them will have a half degree or so. 98.3 to 98.4 Fahrenheit is not much of a temperature bump. And for most clinicians, they would miss this as a diagnosis as potentially now getting sick. So they have this gradual incline beforehand. And what you can't see in there, the people who end up getting infected, they start having temperature variability 6-7 days before they get to their Tmax. So if you organize this in a slightly different way, this red line is those people who eventually achieved a temperature of 38. And you can see that's about 20% of these folks' average age of 80. The purple line is the group that was in the middle half, and the yellow line is the bottom quartile of these people with laboratory confirmed infections. And you can see that they have this variability, but the bottom quartile never spiked. They just got variability without much of a spike. And this blue line is the group that tested negative, this thin blue line, which is most of the people. So it's about 700 people that tested positive that make up these other 3 lines. So one of the challenges we have with observational data is remove the selection bias that's inherent in it. But one of the ways you can do it is you can use a nursing home population to evaluate this. They get vaccinated over a period of time, some early, some later, and you can sort of take that as a way to emulate a clinical trial. I'm going to show you how we did this. And in nursing homes, they all get offered the vaccine the same way, so it's not an access issue. They have similar health, so they are relatively similar. And if you're comparing people who get vaccinated now versus later, they are all ones that are relatively similar. So we can look for symptomatic or asymptomatic infection or death. And I'm going to show you how this looks in a graph. So imagine you have somebody who's getting vaccinated. Now you're looking for a comparison group. What if they get a medication? How do you deal with that? What if some of them get become controls here versus there? Can you pull them all together as a single time point? So we design a hypothetical randomized trial around a research question, and then we emulate this trial into using the observational data. So on any given fixed date, say on Monday, September 1st, you have 50 people who get the vaccine, and everybody else is not getting a vaccine. So this becomes a vaccination date, like a trial date. But on September 2nd, you have a new group that gets the vaccine, and all these other people, no longer you can compare these to the ones that got the vaccine the day before, but all of those that were not getting a vaccine could be controls. And September 3rd, so you can add to this. And if you stack all the ones, their vaccination dates, as if everybody got vaccinated on the same day, you then have this control group that is a concurrent control group that is matched at the time of vaccine, followed over time. So I'm going to just skip through this a little bit. So we have some 9,000 people in this. I'm going to skip past this, go right to the graph. So this is the people getting boosted over time. And these are the controls, all of them available at the beginning because nobody had gotten a vaccine yet, who switch into a intervention group over time. And whether you match against one person or you match against the entire population, you get about the same result. So because these groups are eventually the same people, they get vaccinated now or they get vaccinated later, they're incredibly well balanced across all these factors that are hard to do in studies. Because they're so well balanced, there's a lot of adjusting that doesn't need to happen. So if you could pause the recording, sorry. So in this clinical trial emulation and cluster randomized trials, we're taking advantage of this setting. It's less about whether vaccines do or don't work. They work remarkably well, but the approach is how do you use big data? So you begin with imagining a trial. And in the SARS-CoV-2 vaccine case, a trial happened without randomization, and then we could align them and follow them over time. If this is a prospective intervention, say for a common question like nutritional insufficiency, vitamin D or something like that, you could do it, especially if the people who think about it think it doesn't really matter if you give vitamin D or not. It's not a best practice one way or the other where you just automatically get it for everybody. But you could randomize whole nursing homes to saying this is your standard of care and other nursing homes where you don't. And then you could follow them over time to look at claims for pneumonia or respiratory illness and then compare them. This is how we did now 2 separate large vaccine studies with 40, 50,000 people, currently an antiviral study where we have 1,000 nursing homes, which is 90,000 people. And then you can adequately power this. And it's a much more cost-efficient way to do this. So here's the quick summary. SARS is a potentially debilitating and lethal disease in older adults, especially in the most frail, like those living in nursing homes. Reasons for susceptibility increase with age, but are multifactorial: anatomy, multimorbidity, immune senescence, nutrition, exposure risk, and so forth. Clearly, immune response declines with age, and vaccines give great protection. It's not yet settled if vitamin D supplementation will improve SARS-CoV-2 outcomes, but there is room for optimism. We need to settle the dose, the duration, and whether you need deficiency for this to actually give a benefit. And we can use big data as a powerful opportunity to evaluate interventions and outcomes. Okay, so I'm sorry I went right to the top of the hour, and I can answer some of those questions if I may go on.
Absolutely. Thank you, Dr. Gravenstein. That was very interesting and extremely informative. And as our audiences know, this will be posted online. So you will have the online material that was just presented, as well as the Q&A session. This session concludes our spring seminar series. So thank you to our audiences for all your participation through this spring seminar. If you can stay on for the Q&A, that would be great. If not, as I pointed out, the recording will be there. So thank you, everyone. And thank you again, Dr. Gravenstein. Our first question is from Kelly Cara. She asks, can you address clotting related to COVID infection and clotting related to COVID immunizations? Specifically, some pathologists have reported white stringy clotting material in autopsied patients that they had not previously seen. What might be causing this?
It's a great question. So it's a complicated answer. I'm going to give you two parts. The first of these is most of the coagulopathies associated with vaccines has been with adenovirus vectored vaccines, less so with the mRNA vaccines. The signal for clotting from mRNA vaccines is pretty close to zero. With adenovirus vectored vaccine, however, this has been reported with those vaccines back as far as 2007, when they were being given for other things. And those same clotting abnormalities you can get with natural infection. So the thinking is that this might be a unique feature of the adenovirus as a vector. So the risk of having a clot, whether this is a portal vein thrombosis or a pulmonary embolism or any of the other things that have been reported, seems to be, a real risk with adenovirus vector vaccine, which is both the AstraZeneca vaccine and the J&J vaccine have this, but it's a tiny risk compared to the risk of being hospitalized or dying from COVID. So if one were saying, do I get a vaccine and take this chance versus no vaccine? Well, in my mind, I would like to take the vaccine with the lowest risk, but if I don't have a choice, I'd be reaching for that, because I think it's inevitable that we will all eventually get infected with this virus. And whether that's today or a year from now or 2 years from now, it's going to become endemic and we'll keep getting exposed to it. And at some point, even if you're really good about wearing masks now, you're likely not to become Japanese and wear it every time you get on a subway. So the second question, I see it from Kelly, is there a public available version of this presentation or a similarly detailed presentation? I think this would answer a lot of questions for people who have remained skeptical about the value of masks and vaccines. But the latest online video I see from Dr. Ransom from 2021.
Yeah, I did not ask you the question simply because we're going to be posting this, and thank you for agreeing to have this be publicly posted. We will have not only our folks, but also everyone have access to it. So yeah, so it, like I said, it was very interesting and informative. So I think there's a lot to be learned from listening to this, and it's beautiful because it's all contained in one place. As you can see, there are no other questions. Does anyone want to ask a question? If you didn't get a chance to post it, you're welcome to ask now. If not, I think the presentation was so clear and has really been informative. So the lack of questions does not reflect a lack of interest or follow-up or clarification needed. It just is one of those presentations where we heard everything that we needed to hear. So thank you so much, Dr. Gravenstein, and we will look forward to all the work that's coming out of your lab and your collaborations. Thank you.
Thank you. Thanks for having me.